Hello friends, I am Dr Sourabh Patwardhan from Nandadeep Eye Hospital, PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. In this video, I am going to show a technique of vacuum chop for grade 1 cataract. Now, and using my chopper, which is 1.5 long, it's a blunt chopper. In these cases, generally I use the phacoaspiration technique where I just do hydroprolapse of the nucleus and then just aspirate it out. But in few cases, if I'm not comfortable with prolapsing out the nucleus, like the AC is too shallow, then I use this technique. Also, train divide technique is very useful for the softer grade of cataracts if you are using the right chopper. Now, once CCC is done, initially when I injected the fluid, there was deepening of the anterior chamber. That means it's not going in the right direction. So I changed the direction. I could do a good hydrodissection, also good hydrodelineation. Now this golden ring really helps in this technique because then you get a guide like where you have to pierce the chopper. So after removing the anti-epinucleus, I am going to use very minimal phaco here. You can see the CDE. You will find that I have used very minimal after this, that I have hardly used any phaco energy. The power settings are really less, but I am going to use vacuum. So I bury just little bit without using much of phaco and then watch the chopper movement here. It goes from the edge of that hydrodeneated nucleus and it's similar to mechanical chop, but I am using vacuum here to hold the nucleus and I'm not using any phaco energy to bury. So, and also while doing heminucleus, you can see that I'm just sharing it. I'm just separating the two by sideways movement of my phaco tip. So the vacuum just splits that heminucleus, which is really soft, and then approaching the pieces at the anterior edge of the nucleus is really important. This is how it should be, the bevel sideways at the anterior edge of this heminucleus there. You should not go for the central part of the nucleus, otherwise just you will just punch through and through. So always in these soft grade of cataract, when you're doing quadrant removal, for that matter all kind of cataract, the tip should be anterior, just below the capsular level, and it should not be going into the material or the central of the nucleus anytime. So that kind of pulls out the nucleus pieces and you can just phacoaspirate it very easily. Now usually for these kind of cataracts, though you can use multiple techniques, I would suggest that try to stick to one or two techniques so you get reproducible results, and don't do it somehow. Many people change their technique in between and they get stuck, and finally there is a bowl and then you have to hydroprolapse or viscoprolapse it and aspirate it out. Here I'm getting little bit of difficulty in subincial cortex there because the PC is also little bit redundant, but you can see that I'm using low vacuum there and trying to pull out from anterior cortex. If anterior cortex is difficult to get sometimes, you can also approach from the posterior part, but you have to be very careful to separate it out from the posterior capsule and pull it out. This patient had opted for a toric trifocal IOL, so that goes into the back. Callisto markerless system there, helping me with the final positioning of the IOL there. And always in these plate haptics, you have to make sure that you remove all the viscoelastic from the bag as well. So that is one of the most important steps in the phaco surgery. I know that few surgeons tend to avoid it, fearing that they may hold a posterior capsule while doing that, but I think it has to be removed because that leads to post-operative comfort for the patient, as well as you get more refractive stability in toric IOLs as well. Wound is hydrated and that's the end of the surgery. For more videos, do subscribe and do comment what you will do differently. Thank you.